Supriya, you can give us a count.
Okay, sir. We're live in 5, 4, 3, 2, 1.
So you can start the recording also. So good evening, everybody, and welcome to the worthy webinar series presented by W.O.I.C.E. And it's an honor to introduce our convener for today, Dr. Rujuta Mehta. She is a very well-known pediatric orthopedic surgeon across the globe. And most importantly, she has been listed as the top 20 women achiever in modern medical care, as well as she is the founder and chairperson for W.O.I.C.E. India and founder secretary for APOA Women Orthopedic Advocacy Cell. That's the WAVES. And our co-convenor, Dr. Chasanal Rathod, she is a pediatric orthopedic surgeon affiliated to SRCC and also many major hospitals in Mumbai. She has been trained internationally and has received many awards. And we are glad to have both of you with us today. And thanks for doing it in collaboration with OrthoTV. We both are here to support. Thanks very much.
Thank you, Ashok, for that lovely introduction. And it's always a pleasure doing programs on OrthoTV because I think together we really achieve maximum. So without much ado, first let me share a few things about W.O.I.C.E. Is there slides are visible? Okay.
Yes, ma'am.
Yeah. So as you know, W.O.I.C.E. is Women Orthopedic Surgeons of India Collective Empowerment. We are a recognized subset of IOA itself. And this entire series is being held in memory of late Dr. P.K. MullaFeroze. We started the first one on 3rd October, which is her birthday, and which is also celebrated as the National Cerebral Palsy Day since 2005. At the Golden Jubilee IOCON in 2005, a few of us women came together and we realized that there is a platform in CCOT for the women, but none exists in IOA. And if you just see the number of achievers, almost 7 Indian women have received the Marcela Uribe Zamudio Award. And therefore, we thought of forming this in the IOA. This is our main charter that we really look at, that we do a lot of community awareness drives. We have been trying to increase our membership and it's almost stands at 290 now. We hold regular CMEs and also a counseling cell because I think women feel a little more comfortable asking or talking about their unique problems to women. In addition to this, we also have UA scholarships now, and every year at the IOCON a dedicated 1-hour session. And we've also instituted a best paper prize in Dr. P.K. MullaFeroze's honor. So I think W.O.I.C.E. has really gone from strength to strength. These are just some of the glimpses of the programs that we've done since 2017 and 18. And Shobha ma'am, Risha ma'am, these are some of our really good guiding lights. And we are so fortunate to have Shobha ma'am with us today. Chasanal has always been one of my regular colleagues and most reliable and trustworthy partners. This year, we had a very unique program, of which one of them is the chairpersons today, Dr. Dhaval Desai, where almost 25 girls, as you can see over here, received a training of the trainers. And I think that went a really long way in helping them do their presentations and collate their data again and again. And we're fortunate that along with Tanya, each of the members of the WAVES Council, that is the Women Advocates of APOA, Advocate, Educate and Support, which is a newly formed organization within the APOA, is there to further collaborate and liaise. So I think the future of women orthos is sounding pretty exciting, and we are really glad to have Tanya on board with us. And together, I think we'll be able to steer the APOA and India to greater heights. So Tanya, Chasanal, please welcome our chairpersons and speakers and talk about Worthy.
Yeah, so thank you so much everyone for joining us for this webinar. And like Ma'am Rujuta Mehta ma'am just mentioned that how this webinar was just started and how did we plan and implement this entire idea. And today we are on the 3rd week of the Worthy webinars. And with us today, we have we welcome Dr. Tanya Burgess and of course Dr. Dhaval Desai sir. And I request ma'am to introduce our chairpersons for the webinar today.
So Tanya is the chair of the Asia Pacific Orthopaedic Association for Women's Advocacy, that is WAVE. Like I said, women of AP or educate and support. She's the education committee member of the Asia Pacific Association, the director of training at orthopedics at the John Hunter Hospital, an astute hand surgeon in herself, and she's also been a scientific secretary with the New South Wales branch of the Australian Orthopaedic Association. She's part of the mentoring committee of the AOA as well. Tanya is a very, very systematic and serious-minded person, and I'm sure she will be a great leader for WAVES. I would also like to introduce our other chairperson. Chasanal, can you change the slide? Dhaval Desai, a very, very thorough gentleman, a very close friend and colleague. He's been the chair of the AO Trauma in India since 2021 to 2024 now. He's education officer at the AOA India from 2014 to 18. He's the member RET AOA TP since 2011, a past president of the Gujarat Orthopaedic Association. His specialty is faculty education and coaching, but of course he's a hardcore trauma surgeon. And he's also a consultant orthopedic surgeon at Surat, India. His interests are pelvic acetabular trauma, complex trauma management, and orthogeriatric care. Dhaval Bhai is very passionate about teaching, and he has promised us year after year to do the training of trainers for the women. So thank you, Dhaval Bhai, and welcome, Tanya. And I would request Chasanal to introduce our illustrious speakers for the day.
So the worthy webinars was all regarding talking about what the webinar or what the talk was really worthwhile about the speaker. And the first person whom I actually contacted was Shobha Arora ma'am. And ma'am was, I'm very thankful to you, ma'am, for giving us this time and joining us for the webinar. And while I was student, I had always looked upon to you and few of the other women orthos while taking up ortho like more than a decade ago. So thank you again, ma'am, and welcome to the webinar. And we have Shobha Arora, ma'am. She has been a great teacher. And for 25 years, she has been faculty at UCMS Delhi. And she's the one who has initiated and started MCH courses in 3 orthopedic super specialties. So, and currently she's professor and head department of orthopedics at AIIMS Rishikesh. And I think ma'am has just retired. Sorry, ma'am, you just retired in June 2021. And thank you so much, ma'am, for joining us today. And the second speaker, Dr. Ramesh Kumar Sen, sir is not being able, sir is en route and his flight is a bit delayed. He's not able to join us live for this webinar, but I'm sure by some time he'll surely join us. And he's known for his orthopedic practice of around 32 years of practice, and he's author to many research papers and chapters in books. He's faculty for national, international, and many regional meetings. He's faculty at AO and other courses globally. He's a visiting professor in Germany, US, and Canada. And he has been faculty at various live surgical workshops and Sorbonne and cadaveric workshops as well. And apart from this, he has many international and national awards, as well as he has been founder president of AOPS and past president of NZOA. And currently he's president-elect for the IOA 2021. And he's member of the AO International Pelvic Expert Group. So thank you, sir, for being part of this webinar. And we look forward to your talk. So now we begin with Shobha ma'am. And ma'am, requesting you to please share your screen and start the talk. Thank you.
Thank you, Rujuta and Chasanal. I am sharing my screen. My screen is visible?
It's just about, yeah, ma'am, it's there.
Right. Good afternoon, good evening, everybody. I have picked up a topic which is not a very fancy topic in the modern part of orthopedics, because this is an age-old entity and people don't like to discuss much about it unless there is a fantastic reconstructive procedure or something. I am taking you on a different tour of chronic osteomyelitis, and this has been our work in AIMS Rishikesh along with Department of Pediatrics. So this is worth sharing. The points which I would like to discuss is the why of hematogenous osteomyelitis, identifying the why in each patient, and then planning your long-term strategies as well as immediate strategies on the basis of these factors. And I hope I'm going to give some new ideas in this topic. Hematogenous osteomyelitis is typically a distinct pediatric entity, but we do see it in older children, which is a big problem, and we'll discuss that also. I'm not going to touch much on adult hematogenous osteomyelitis because it's uncommon, rare, and under special situations. What information do we have about hematogenous osteomyelitis? Ever since we enter our undergraduate courses, we learn the classifications, we learn the local pathophysiology of the hairpin bends and the antibiotic protocols, and then we go on to the surgical interventions during our residency and PG. And then as a consultant, especially in government hospitals, you learn the reconstructive procedures almost customized for every patient. We have this information, but I take you through this typical slide which we have been seeing from our clinical childhood. Do you consider this to be the event, or is it a post-event change? This question needs to be addressed, and I'll come to it why this question is important. To me, this is a post-event change. The event has already happened. This is not happening. This has already happened. So what has happened, and what are the things behind this? Okay, so for that, I'm going to just regroup our patients. I'm not offering a classification. Parts of this are definitely in every classification. So let's take neonates and infants as a separate group. We'll discuss it why. All other children up to 14 years of age are into one other group, and 14 to 18 years adolescents, hematogenous osteomyelitis is very, very uncommon, yet I'll still keep them in, and adults, of course, is not part of this discussion. As we know, I'm just reiterating what we have been seeing. Most of the patients, children with hematogenous osteomyelitis in this country, especially in government-free hospitals, are coming from low socioeconomic profile, multiple siblings. In the better society, probably some drug addiction is there, and there could be metabolic derangements. This is all very well documented information. Now, the why of chronic osteomyelitis is around the concept of tissue-specific immunity. I was excited when I came across this entity for the first time during my fellowship in the 90s. And ever since then, I have been working on this. And recently, we have published a thesis with MD Pediatrics people on this, and it has proven the concept. All of us know that circulating bacteremia is the first event to happen before any hematogenous infection in the body of a child occurs. Now, what happens is when there is circulating bacteremia, it gets converted into septicemia because of immune compromise or slight immune decline, you may say. And then the tissue localization is permitted to form a localized disease like an abscess, for example. And this local permission for the infection to be allowed to settle into a particular tissue has a tissue-specific immunity. This is very exciting that not all the tissues in the same person's body will allow localization of the infection in it. And there is a specific local cellular defense which differs from system to system, organ to organ. And this is the cause, the why of chronic osteomyelitis. So if you take the frequency of localization and manifestation of a bacteremia going into a infection that is localized, commonest organ which allows localization quickly is the skin. So that's why boils and abscesses in children on the surface are pretty common. Probably the commonest of skin infections are skin. Then you get the upper respiratory. The respiratory tract allows localization to some extent. The lower respiratory tract also sometimes allows to go into pneumonia. When this infection is allowed to settle down into meninges, then comes meningitis. And this and that and that and that infection. Mind you, At the end of the list, there is osteomyelitis and septic arthritis. That means this is the last organ to be allowed to invade. And once you have the osteomyelitis, that's why I said once you have the osteomyelitis, this is the this is the last localization permitted failure of defense at the local tissue level. I was really concerned about this fact when I came across this statement for the first time studying the pathology of this whole situation, that if you have a child with osteomyelitis, that means his immune system has allowed the infection to go deep into the bone. And if you go by the definition of osteomyelitis, myelitis, the marrow is the one that categorizes it from osteitis or just the superficial infection. Now, what are the local defense of various tissues? I'm taking you a little bit onto the lab side. The macrophages and the dendritic cells are the cells which are the usual defense system in all other organs. And when we read these terms like lung-specific and marrow-specific dendritic cells, please remember marrow-specific dendritic cells are not for the bone marrow. They are derived from the marrow, but they are circulating everywhere, and they have more role to be played in other organs rather than marrow itself. And of course, in tuberculosis, you have the B cells or the lymphocytes working as the local defense tissue. That is a different immunity at all. And this is just a diagrammatic representation of how a macrophage converts into a dendritic cells and the different parameters which differ between the two, but dendritic cells are the ones which fight against the circulating septicemia. Now, if you say dendritic cells and macrophages are the defense system, is it true for bone? No, there's something before that. I can't say that macrophages are not working in the bone, but the defense of the bone is osteoblasts. The number of osteoblasts in a child's marrow is the one that decides the child's body allows the infection to be settled into the marrow or not. So osteoblast is the defense of the maturing bone to let the circulating infection localize in itself. And if you have osteomyelitis, the osteoblasts have failed, the defense has failed. So it is a defenseless bone, and it is the last organ to allow. So if you say that, you mean every osteomyelitis child should have first a meningitis, a pyoderma, and a URTI and LR? No, it's not like that. When the infection finds the bone to be defenseless, it will quickly pick up the bone. It will leave rest of the tissues. So the defenseless bone is the weakest of all hosts, and this also weakens the macrophages and the dendritic cells which arise from the marrow. And that's why it is so easy to attack, destroy, and form pus in the bone. That's why I showed the diagram. Say it's a post-event thing. What we learn at the hairpin bends and the superior osteolapsus is a post-event thing. Event was this: the osteoblasts were gone, already gone. Why is it so? Because to attack a primary school with a gun is easy. There's hardly any defense in children. The same thing, the immature marrow cells. If you look at the immature marrow cells, these marrow cells are so easy to attack. Once their defense is gone, it is gone, and they're vulnerable. That's why you get so much of pus in osteomyelitis, acute osteomyelitis. So again, on the why of osteomyelitis, why does this happen? Why do the osteoblasts allow the circulating infection to settle down in the bone? Because these children have a perpetual insufficient glucose supply for the growing cells. They have reduced numbers of cells, not exactly the reduced TLC as you see in a lab count TLC or in a CBC, but their general growth pattern is stunted. They are malnourished children. If you don't say like a kwashiorkor or something, yet they are less than their average health of the age, and they also have low iron depot. Therefore, the circulating oxygen levels are also low. That means they have insufficient and starved macrophages. When you see this kind of an MRI, where there is already a change in the metaphysis showing that this is a impending osteomyelitis, or already the bone has been invaded, the defense has been already broken. Osteoblasts have already laid down their weapons, and the infection has entered into the bone. The event has happened. And when this has happened in a child, if this much destruction has happened, I parallel it with this. This was the Pulwama bus. So this and this are at the same level. This much destruction has been done. It's already done. So when we are talking of management of osteomyelitis, what is lacking in the protocol? Why this happens? Why do we detect osteomyelitis once the circulating infection has gone inside the bone, whether on an MRI or an X-ray, or clinically a bone jutting out or a sinus coming out there? We have never recorded the oral intake of the child. And ever since the child was sick or was not sick, was he eating properly? How much was he eating? This is part of history. We did not calculate the calorie deficit when the child came with osteomyelitis, and how many extra calories for healing are needed needs to be calculated. That is the lack in the protocol. So the treatment protocols which we have learned is good. They are fine. They are in place. They must be used. IV antibiotics, evacuation of pus, oral antibiotic, chronic osteomyelitis, debridements, you put supports, everything is fine. You have some chronic osteomyelitis, especially up to the 14 years of age children, the older children between say 8 to 14 years, I would say, they have recurrent, non-healing, repeatedly reactivating osteomyelitis with gradual bone destruction and a lifetime stigma of osteomyelitis. And non-healing sinuses in older children, as we see here, you do repeated cultures, repeated debridements, IV antibiotics as per the culture and sensitivity reports, some vitamin supplementations, but they don't still heal quickly. The sequestrum persists inside, the sinuses persist inside. So the new strategy of management which we used in our institution and on which we have done a lot of work was to allow and encourage local healing response by improving the systemic healing response. All our orthopedic targets are the bone. We want the sinus to heal, we want the involucrum to form, but we are not doing sufficient for the systemic healing by calculating what is the deficit. Now, this is a very simple thing to do. At the OPD level, if you are treating a chronic osteomyelitis child or an acute osteomyelitis child, older child, I leave infants and neonates on a separate note. Ask the OPD patient to keep a meticulous diet diary written. Next time the patient comes, bring in the diet diary of 5 days or 7 days or 3 weeks, whatever is your follow-up period. Admitted patients, we ask our nursing staff to keep a diet diary, how much and what the child has eaten or not eaten. Then we calculate the standard daily calorie intake for the age 6 of the child and match the actual calories that the child has been taking, which calculates the nutritional deficit, calorie deficit. I insist on that. Now, the catch in the calculation is that if you take the normal standard calories, the healing of any surgical wound, as we know, requires 1.5 times more calories than the normal intake. That deficit needs to be adjusted. So a small deficit is, and mind you, these children do not eat the way they should be even normally eating. They are already starved children, starved in the sense, not the starving, but they are low on their nutrition. Normally what they need, they hardly eat anything out of it, and the deficit is huge. It is large. When you calculate it, you are at times flabbergasted with such a big deficit that they have. And this deficit needs to be calculated every day. And then how to correct the deficit? They don't eat a full meal like adults, like roti, sabji, dal, chawal. They don't eat all that. They won't eat at all. So you are worried that the child does not eat, right? A child will not eat. Don't insist on the child to eat cake, roti or khalun. No, he's not going to eat one more chapati if you ask them. So what we planned in our strategy for treating these children with our nursing staff is that we give them small, frequent, rich snacks or sweet drinks over and above the normal meals, and then calculate the total calories. I think Dr. Tanya will not be familiar with these, but everybody else knows that sugarcane juice, commonly seen in this country, 260 calories in 100 ml. Very easy to have. And if you're worried about the gastric disturbances, don't worry. The child is inside your hospital. You can take care of that. Popsicles, ice creams, kulfi. This is such a rich thing, and children love it. You ask them, okay, you don't want to eat food, you have 2 kulfis. Okay, you don't want to eat food, you don't want to have 1 chapati, you have half a glass of sugarcane juice. Or you can have packed juices. Oh, you want a chocolate? You can have 2 chocolates. You want a candy? You can have 4 candies. And if the patient is not able to afford all these things, the plain simple street vendor who sells all these things, the peanuts, the peanut chicky, peanut chikki, the tilki chakki and gajak and everything. This is all very, very nutritious. Traditionally, what we have been eating in India in winters and summers is very, very useful and good for these children with chronic osteomyelitis. Children who do not like to eat sweets, there are children who do not like to eat sweets. For them, what you avoid is good for them. Potato chips, peanuts, coconut, pieces of coconut, all this is very, very healthy. If the child is at home, ask the mother to make some atike laddu, make some simple nut mixture, and the child can snack on it every time. So binge eating or rich snacking is one of the easiest way to compete with the calorie deficit and to take the child's calorie intake higher than what you expect in 3 square meals. Now, every time you go on rounds, you write HPD, high protein diet. So what about high protein diet? Do we really need a high protein diet? Well, mind you, the macrophage pathophysiology, I'm not going into the detail of it. So though we have worked on it, the calorie deficit needs to be corrected. That is the top priority. The reason is that the glucose metabolism of the macrophages and the dendritic cells is the priority to fight the bacteria, and then the osteoblasts come in. They restore, they multiply, and they also need a whole lot of calories. And normal protein intake is sufficient. Proteins need some calories for digestion, so your calories will be diverted to that also, or the calories generated from the proteins will also be used for protein digestion. Normal amount of fat is also okay. So HCD, not HPD, but HCD is our motto in treating these children. The concoction which one of our dietitians gave us as a very good formula is, she said that you add 3 TSF of sugar, 1 TSF of any protein supplement powder, and 2 TSF of ghee or any other fat form that you want. Ghee is the simplest thing to add in milk. And this concoction can be had at 6 a.m., 1 a.m., 11 a.m. Sorry, that's a mistake. 11 a.m. and 6 p.m. Normal meals are not disturbed by this. This is like very rich snacking again, or liquid snacking, those who don't want to eat anything. Iron supplement, again, target to achieve the ideal hemoglobin for the child. Don't go for injectable, but oral supplementation of iron is important. The usual tendency is, okay, hemoglobin 10 gram, fine. No, it is not fine. Please understand, 10 gram hemoglobin for a child is very poor. You have to improve upon the hemoglobin for your systemic healing of the sinuses that you are worried about and every time debriding. Pediatric opinion for treating anemia and the long-term treatment of anemia can be taken. Also, one of the simple things that we realize is that you need to mobilize the child in a wheelchair. Don't keep the child in the ward. You have operated, all right, but if the child can sit in a wheelchair or on a trolley, just send him out. Let him have some breathing outside, and the whole atmosphere, external atmosphere, that the child knows I am out and I am out of the room where I have been jailed. That's what children sometimes feel. They eat easily. This encourages the intake, and then as soon as possible send the child home quickly. What is the proof of your treatment effect? You have been doing some evidence-based medicine, or this is just somebody's fancy? No, there are treatment effects which are visible. The local sinuses start healing faster than what you expected with your antibiotics. New involucrum starts forming. Faster healing of pathological fracture occurs, and the child is more active and more cooperative to your treatment. Now, some specific situations I'm going to bring in. Tubercular long bone osteomyelitis is a difficult diagnosis and needs a little experience also. It is totally diaphyseal. It may be in an older child and it is diaphyseal. The sinus will give you a watery discharge. Please remember, it is not serous, it is not purulent, it is not seropurulent, it is totally watery like CSF. That is one of the diagnostic criteria of that. And the sequestra that may be there may be microsequestra and could be only cortical if it is a long sequestrum. In these children, we have been checking CD4 and CD8 count for immune response. This is a typical patient, 2 patients rather. This is a cortical sequestrum that has come out of the tibia, and this is a total diaphyseal osteomyelitis. Similarly, the fibula also in this girl was involved, and she had an abscess pointing right at the lateral malleolus here, which we drained, and this is postoperative, so there is a little scarring visible there. So diaphyseal osteomyelitis with a cortical sequestrum, more sclerosis than anything, likely to be tubercular long bone osteomyelitis. And this is a typical sinus which has pigmentation around it, and the discharge is watery. It is not serous, it is not purulent, it is a watery discharge. Flat bone osteomyelitis, which we, sorry for the spelling mistake there, flat bone osteomyelitis like ileum. and scapular osteomyelitis indicates a further poor host, the lowest of immunity, because these are vascular bones. The vascularity of these bones is way, way higher than long bones or the cortical osteomyelitis or the osteomyelitis of long bone. And if a child presents to you with an ilium osteomyelitis or a scapular osteomyelitis of hematogenous origin, this is a very sick child at presentation, please remember. And we have found that the involvement of hip joint and SI joint is common. These are the metaphyses which you get in a child's pelvis and hip area, and you can definitely have iliac osteomyelitis, which makes the child very, very sick. This entity is awareness on part of the surgeon that you should be aware of this entity in a sick child. If there is nothing in the hip joint, check the ilium, check the flat bones. Now, infants and neonates do not fit into this diet program because you need a pediatrician to plan a different nutritional strategy on breastfed babies. And I'm not sure whether they would advocate giving MVI in drips or not, but nutrition, definitely oral parenteral nutrition is something which is to be planned by the pediatrician in these children, neonates and infants. Their immune system is different. So the summary of the management I would like to say is go into the history of the child's general health, the social history, how many children are there, how much does the child eat, what is the likes and dislike of the child. The local site can be treated as per your guidelines. We definitely do not compromise anything, and everybody is well versed with the guidelines for management of chronic osteomyelitis and acute osteomyelitis drainage. But I would suggest that unless the bone quality improves by your systemic response, please do not jump into heroic reconstructions of MullaFeroze and bone transportations and grafting and anything, because it will be an utter failure. Unless the host is on your side, on the healing side, your excellent surgery will not be rewarded the way you expect it to be. And the involucrum is the guide for the progress. The involucrum, better involucrum is formed, definitely the child is healing well. So my carry home message is that osteomyelitis is an attack on the core immune system of the child, as well as the local immune system. Local defense is totally broken down. So improve the immune response aggressively by nutrition. No HPD, but HCD. Give high calorie diet, pump in calories as much as you can. And antibiotics won't work without the inherent macrophage and dendritic cell response, which is the defense response against the septic bacteria. Thank you very much.
It was an excellent talk, madam. I think you really clarified a lot of our perspectives about osteomyelitis. I'll request both the chairpersons to discuss the topic.
Dr. Shobha, thank you very much. That was a absolutely fabulous talk, and I certainly learned a lot about osteomyelitis, which is does not form a large part of my practice in hand and wrist surgery. I'm fascinated by the nutritional side of things. I've got two parts to the question. How long does it take for a change in the patient's diet to demonstrate a change in their clinical symptoms? How many weeks or days do you think you have to increase their caloric intake before you notice that the host body is really working hard to fight the osteomyelitis?
I would divide that into two answers. The one response that you get in children with acute infections, you have drained the area, you have done your surgery, you have pumped in antibiotics, and you are giving the fluids and maintaining every vital sign well. This child has not been eating for at least past 48 hours or 72 hours. And when you start pumping in calories for this child, he would show response within about 7 to 10 days. That's quick, because it's like acute treatment. You treat them with antibiotics, they respond. You treat them with nutrition, they respond. But the problem comes in older children who have been having chronic lurking infections in their bone. They don't have systemic signs, and they are the nutritionally lower ones as compared to those who have the acute response. So these children, once you start them on nutritional management, will take at least 3 to 6 weeks to show the slight improvement. And I would say that in our experience, at least 3 or 4 patients of mine have taken 3 months to show some response. But it is worth it because within those 3 months, their sinuses start healing, their involucrum starts forming, which indicates that they are doing good. But to get the real response for a reconstructive surgery like a Lilizarov or a bone transport takes about 3 months' time.
And when they go home from hospital, do you have difficulty maintaining that nutritional intake, or is education a real key with the older group of patients to maintain that when they're out of hospital and out of your sight, so to speak?
I think education is good because what I showed on the vendor's cart is a very cheap thing. It is available everywhere in the village in India, and this is popular. It's nothing prescriptional. You don't prescribe California almonds to them. It's simple peanut. It's simple sugarcane that's available locally, and in Indian villages there are fields and this comes practically free, you know. So these dietary advices is just emphasizing that whatever is available locally is good for your child. Please give him local things. That's education, and it works. It definitely works. The children like it and parents find it easy to comply.
That's excellent. Thank you.
Dr. Shobha, it's a very interesting concept that I heard, and I think in an area that probably not many people have given or drawn attention to. So this concept to be carried forward to surgical treatment of surgical patients, do you have also used, the role of nutrition in surgery in patients with chronic osteomyelitis, and does it have made a change in impact or their recovery times or healing times, or have you studied that also?
So this is a very interesting question, and I'm happy because when I searched the literature, there's hardly anything on post-operative orthopedic clinical nutritional concepts in the literature. Most of the post-surgery literature on nutrition belongs to the surgeons, because then they think of electrolyte loss and balancing the electrolyte loss orally and this and that. Nobody talks of orthopedic patients. So this question comes in very important for practically every orthopedic patient, I should say, especially if when you are doing pelvic surgeries of that level, your patients should be encouraged to go on for a good nutrition. And good nutrition does not mean ghee and badam, but it definitely means that the calorie intake should be increased. Somehow we have been given this idea, HPD. I have been counteracting this concept so badly. First of all, the calories need to be completed. And you asking about children admitted in our ward, indoor patients? Yes, this is all indoor training to the parents that this is what we should be giving them for eating. We don't give them hospital special things or anything, but just simple things which I showed. And I would suggest that major trauma patients, adult major trauma patients, if they are not diabetic or if they do not have a metabolic problem, you can chart their diet deficit, the calorie deficit, and correct it. Till healing will be very fast, very, very fast.
I think that's the most interesting part of your talk, is you give a very simple solution to the problem. It's nothing fancy, it's doable and doable all across India. I mean, that's what's very interesting. Thank you.
Thank you.
Can I add a question to that? Ma'am, since you've really studied this in detail, is there a difference in the pandiaphyseal osteomyelitis that we see, or the multifocal osteomyelitis that we see, and especially the children with sickle cell, or some of them who really have a high parvovirus count and they need to be given IgG and things like that? So is there any special formula which we could use for those children?
I don't think there's a difference in the nutritional components to be provided, but definitely the immune compromised status of these children need to be medically taken care of. You correct the nutritional balance like you correct it for anybody else, like the common patients, but these children will need some special medical connection, medical attention, because you are in a sickling belt where I was also there in Nagpur. So we have a lot of sickle cell patients there in that area. They are a combination of medical as well as surgical combinations. So you will have to take care of the medical component medically also. It's just
so
not,
what I've started very recently doing, of course, I mean, I didn't really have this line of thought, but when the one particular child came in with both tibia, both femora, and both ulnas involved, there is a we have a very strong burns unit in our Wadia Children's Hospital, and they give something known as a buttermilk diet. So which means they mix 2 eggs, bananas, ghee, sugar, jaggery, and buttermilk all along as a really thick concoction. And that's what I've been trying. But I mean, yes, of course, there is some healing happening, but every time the parvovirus count goes high, the child again starts, throwing some.
Yeah, the concoction.
discharge.
Yeah, it's the same similar concoction that I said. It's part of that strategy only. However, I would suggest is, why don't you first calculate the deficit, the intake? That is more important. Go objective. Go objective. Keep a diet diary for 24-48 hours when the child is sick and calculate the deficit. Once the deficit per day is calculated, then you correct it by small rich things. If you give 100 ml of milk with that much thick things in it, the child is not going to sometimes swallow it. With child having 6 bones osteomyelitis, probably is going to refuse eating that much also. So the small candies, small chocolates, they are very rich sources. All those things which we are afraid of eating because of putting on weight are good for the child. So what you don't want to eat, give it to the child.
That's a really good one. And if with the chairperson's permission, if I may just ask one more thing, do you believe in using at least a joint spanning fixator while we do a lot of debridements and wait for the nutrition to pick up, for the child to overall heal, for the sinuses to settle, and then go in for the fibula grafting? So would you advocate a joint spanning fixator at least, or not even that, and you would say just maintain in a plaster and keep doing a window dressing?
I think, Rujuta, this is a very customized question. I would see the child, I would see the lesion, the quality of the bone, how much is the sequestrated diaphysis, how much is the joint involvement. Then only you can plan whether you want to go across the joint, or you just want to treat it conservatively, or you want to do something else also. So that is very customized thing. Depends on what the picture is like.
Okay.
I would see the whole child. I mean, going by a holistic approach, how sick the child is, what is the local lesion like, and what are the other components or other conditions which are favorable or unfavorable. This all will decide what I really want to do surgically on it. But yes, spanning fixator is one of the parts of strategies. Yeah.
Any other questions from Tanya and Dhaval bhai?
No, that was excellent talk. Thank you, Dr. Shobha.
Thank you. Thank you.
That was an excellent talk. Thank you.
Thank you. Thank you for the opportunity to the organizers, and thank you to the chairpersons. Thank you very much.
So now I'll share the video which Dr. Ramesh Sen sir has just shared with us, and it's a pre-recorded talk. And so we go.
Good evening, friends. I'm thankful to Dr. Rujuta to have started this series of lectures in the memory of late Dr. MullaFeroze, our first lady orthopedic surgeon. Let me share my screen. Looking in orthopedics as a specialty, this is something where we have the least percentage of women, and probably this says about less than 1% in India, while this is a reasonably much bigger number in other countries. If you look at the list of it, there is recently a topic published which says there are countries with the highest numbers, with Estonia topping, so followed by Sweden, Brunei, and there are the countries with the least number. And to start from the least number, yes, India is there, with so-called percentage of 0.5, which is not a very happy comment. Understandably so, this statement that in spite of the efforts to improve this gender diversity in orthopedic surgery, women remain underrepresented, and especially with the increasing academic rank. I'm happy to be today in a symposium with Professor Shobha Arora. I had first interaction with her as a lady orthopedic surgeon when I was there in Yokohama in Japan, in International Congress on Knee and Sports Medicine, where luckily I was one of the invitees while I was doing my residency in my medical college here in India. Dr. Shobha Arora was very kind at that stage to have helped me, especially in the Japanese language, which she was so fluent due to her Pelvic orthopedic fellowship experience in Yokohama, and helping me and trying her best to get me into the same fellowship over there, which somehow I could not avail. And this is the picture when she took me along with to Tokyo Medical College as an observer. And this is now something around 30 years late, I met her in this thing, and I'm very happy today that she has been with the session. Thank you, Dr. Shobha. It has been very kind of you. My second interaction with a lady orthopedic surgeon was Professor Tanya. Again, that emanates from my experience in Yokohama, where Professor Sengupta was there sitting on the dais with me. And he was the one who invited me to Malaysia. And in her department, I met Tunku Sara, along with a very close friend of mine, Professor Soy, very, very close friend. Then Dr. Sengupta was very keen in developing that kind of a relationship that he kept on inviting me. And this is in 2006 when they asked me to be there as an examiner for their part 1 examiner. Then in 2014, I was there as a part 2 examiner, and you can see me down there sitting in that room. And there, Professor Tunku Sara and another lady orthopedic surgeon and another lady orthopedic surgeon. So there were some orthopedic surgeons at the academically good position in Malaysia. Now, there is a very interesting read. This is what it says, that when you compare the cases operated by female orthopedic surgeons, they had less complications, they had less deaths. And that's very interesting and stimulating also, that here the fineness which our ladies will have can be given to orthopedic surgeon experience also. And the another paper said that attracting lady students to orthopedics, and especially the subspecialties that now I'm talking about pelvic vestibular trauma, should be our priority. And I'm happy that Dr. Rujuta has given me the chance to at least introduce this specialty in this form. Now, when she asked me, I looked at the world around. How many lady candidates have been there in our interactive workshops of 4 days, 5 days, world over? This is in Davos, I see one, there were 2 or 3 more. This is in Korea, there were probably 3 out of the batch of 40. This is in Swiss pelvic course, relatively senior person where I was faculty at that stage, I could not see anyone. Here in Australia, in one of the pelvic courses, yes, I could see 2 ladies over there. In England, yes, we had 2 ladies over there. So there were courses, there were some ladies in this pelvic. This is in a developing world. This was in Ethiopia. This is in Malaysia. Yes, Malaysia, I could see the 2 ladies over there at the course. In Sri Lanka, no lady in the course. In Colombia, in Cartagena, this is in South America, we hardly had 2 ladies in that course. But what is happening in India? These are the photographs of the courses which I personally have been conducting year by year till the time COVID struck us. We do not see even a single lady face in all this picture. So many people came, very many of them are very good orthopedic, pelvic orthopedic surgeons. Don't see a lady. Probably our interest in this pelvic trauma has been least in the ladies group. And these are the further smaller meetings or smaller workshops which we conducted many places across the country. And here you could see one lady over here. Here you could see another lady over here. But we were happy that at least one international faculty, Dr. Tanya Burgess from USA, who is working in pelvic vestibular trauma, was with us in one of our conferences 3 years back. So why so? Now let's look back at the history of pelvic vestibular surgery. You look at 3,000 years ago, 450 BC, Rujuta was one of those pioneers. You can see the history where things start is going through Hippocrates, to going through Chairpersons, Melgagni, till the date of coming down to Rujuta letter. So in that history, the reference goes to Rujuta in his Samhita written 500 BC. He described the instruments. He described the whole of orthopedic surgery, including fractures, dislocations. So we do pay our obedience to the great saint. International level, Melgagni had been there, referred well, and this frame. Why I'm putting up this frame is because at least the time when I was studying orthopedics, this frame was there in the board, and I remember to have treated a patient of pelvic fracture and kind of an open pelvic injury by using this kind of close it up. This is a paper of 2005 which looks at this extended prospective ophthalmology, which says that in a population of a lakh, there are likely to be 3 patients of acetabular fracture. And they do get the incidence because their acetabular surgery is developing, so their incidence of arthritis is decreasing with the years. But they further said that we need a specific orthopedic surgeon who specializes in these fractures, so there is a need for this specific specialty. Now, what is happening in a developing world like us? You see, as compared to all other countries, in Asia, the fatalities are markedly increased. When we divide them high income group, low income group, India is somewhere around in between, reasonably high number of fatalities coming up. Because of our discipline on the road. Just for this thing, I can show you this figure, how it's going on. This is the kind of a situation in the traffic we have got it. These kind of a situations make difficult trauma situations where all our services are already compromised, leads to this kind of a, and this is the type of pre-hospital care we have, and till the time the patient is lifted from the place, our management is reasonably odd, and this is the kind of vehicles available in the system. In this kind of a situation, the time when we were learning about the trauma, we knew about the pelvic trauma, was to give traction. And a traction to be given to a greater trochanter, a traction to be given to the leg, and combination of these traction were giving us a kind of a reduction which we were accepting as the only treatment available. I was lucky enough during '93 to have been inducted into PG as a faculty with my mentor, Professor Nagi, and I'm thankful to him to have given me the opportunity to work in PGI as in charge of the trauma. And during this time, because in PGI we were getting patients from adjoining 3 to 4 states, so we had a lot of experience of trauma cases. And there, I'm going back to 1995 when one of my orthopedic surgeons brought his brother-in-law with this unstable hip fracture. There we were reducing, it was displacing, so he says, do subsets. I was in charge of trauma, but I had never done it at that stage. So he says, I have no option. I cannot believe in traction to hold it for that long, so you have to do it. So what we did, we read our campaign. Whatever was done, we went inside, we did this surgery and executed the stabilization. And I'm happy that this patient had 14 years outcome with me, and he was quite good. And that was my first so-called acetabular surgery. But that stimulated me to read about these injuries, a kind of introduction to me, how the surgical adventure is likely to be. But there was no hand, there were no names, there was no conferences at that time which were talking about pelvic trauma. So in '97, I was in Germany with Professor Kinzel. From there, I volunteered to go to Professor Holz to do this surgery. So I went to Stuttgart to have this thing. Then I was in Holland in June. There I was attended one of the meetings also. There you can see my interest in '98 pelvic trauma to try whatever the navigation I can do. Then again went to USA with Professor Helfet, spent some time over there. I met in San Diego Dr. Zolmata also. And in India also, all people who were coming like Professor Romos, who has been a very close friend of mine subsequently, and Cox and Kun, who is also very close friend. I did not miss an opportunity to learn from all these people. And then I kept on attending international meetings wherever the pelvis was done, because in India nobody was talking about it. So this is in Hong Kong. And then I went into one of the cadaveric plus practice courses. Subsequently, in the same year in 2004, learned every time, and here I'm learning the navigation, doing the acetabular fracture fixations. While in the back of us, now looking at a pelvic trauma and acetabular trauma, looking at the pelvic trauma, our all understanding was traction. But then we were observing very interesting situations. Here is a patient, you can see the massive injury. She developed fat embolism. We did not operate upon him at that stage. And you know, the outcome, she did not have any problem. 2 years, she can sit, square, do everything. So it was intriguing why she does not have a problem. Another patient, young 20 years, you can see the kind of a problem in the sacroiliac joint, the pelvic symphysis, but he has no issue. His sitting, standing, everything was quite okay. Another patient, now here we have got a non-union, the pelvic pelvis gone, but he came to hospital not for that purpose. He came to hospital for his ankle injury because medial malleolus was troubling him. He had a pain over here. And so this was intriguing. Why these kind of injuries are not giving the patient a problem, why they are not looking. Now, then we started looking at their actual scoring systems. Here is a lady with a fracture sacrum, non-union. She was able to stand, she was able to sit, but when we really used those scores, we could find her results were not good. She was quite down in her scoring, though life of quality she was maintaining, but when you scored on the pelvis or acetabular, she had problems. So then we started understanding that these pelvic injuries, we can think them in 4 types: anterior-posterior compression injuries, lateral compression injuries, vertical shear injuries, and combined mechanical injuries. We say them anterior-posterior injuries when somebody strikes from the front or back, and the pelvis as a ring starts opening out. And this opening is in a stepwise. First, the anterior part opens out, then our ligaments break, then anterior part of sacroiliac joint breaks, and then the all posterior also breaks. So this has been divided into so-called APC, anterior-posterior compression type 1, type 2, and type 3, depending on this level of lesion involved. And this is one of the small lesions that is the kind of a type A lesion where if it is less than 2 centimeters, we appreciate no ligament and injured. If this is more than 2.5, we appreciate ligaments are injured. But this is a dynamic situation. So we have to be always sure what exactly is the picture. Lateral compression, when somebody is hit from the spine, when somebody is hit from the side, maybe at the greater trochanter level, now the pelvis breaks into. The ligaments are not injured, but the bones are broken. Here, this sacrum is broken. Here, this pubic rami is broken. And these are the oblique kind of a fracture which you notice. Again, depending upon the amount of injury imbibed into the area, we have type 1, type 2, and type 3 kind of a injury situation. You can see here, if it is extremely severe, this side has been pushed in. Another side gets actually opened out in this very lateral compression injury. Here you can see the going in the fracture and the outside going the sacroiliac disruption on the other side. If somebody falls from a height, what happens? All the ligaments front to back are sheared, and this leads to a kind of a displacement or kind of a vertical shear injury. And this is the kind of the spectrum which can happen. Sacrum and hemipelvis, this side slides down significantly as compared to the pelvis, which gives a counter force. Now we need to see this video clearly. We must appreciate that whenever there is an accident, there could be injury in multiple ways. You see here, the first hit, he gets hit, he goes into the falls again at his pelvis, third time pelvis, and the fourth time pelvis. So what it says that at one time there may not be only single mechanism, there could be multiple mechanisms. And these multiple mechanisms create multiple displacement patterns also. And these patterns are described as combined mechanical injuries. Now, what is most important as first treatment is concerned? It is basically to identify whether that pelvic ring is stable or it is unstable. Outcome obviously is likely to be bad with these unstable injuries. And we could have a polytrauma situation or a significant trauma situation where patient's stability and pelvis stability is too matter. If pelvis is unstable and patient is also unstable, it is known that for every 3 minutes of delay in the care, there is an increase of 1% in the mortality of the patient. So there are well-timed algorithms available because their primary management has to be the stabilization of the patient, of the pelvis in a timed manner, which is very, very important. What an average orthopedic surgeon at his place can do whenever he encounters any patient with a pelvic trauma, and especially if there is already a hemodynamic instability, is to apply a simple binder, which is very, very effective and easiest possible availability and usage can be made. If need be, one can apply X-fix subsequently to manage, but these are all temporizing devices. We only use them as a definitive in a very restricted situation, just like a pelvic fracture in children sometimes. but all of them eventually need surgical stabilization. Here we are stabilizing anteriorly and we are publishing our experience in the paper. Here we are doing the open reduction of the posterior pelvis. We have specific maneuvers to reduce these injuries, to stabilize these injuries. We can put plates posteriorly. And along with when the spine vertical instabilities occur, we can do a spinopelvic fixation in addition to these injuries. So there are many ways in which the pelvis can be fixed in the front, in the back, in the spine, depending on the need on case-to-case basis. Incidentally, percutaneous fixations now are the standards for stabilizing reduced sacroiliac displacements, where we tend to have image control in appropriate imaged patients, and that way we can stabilize the posterior sacroiliac joints if the reduction is achievable. That's very important. And then we can stabilize the anterior cortex also. This is an interesting observation because we knew that most of the places there is a conservative management done for pelvis. Whether it is helpful or not, this is the study which we did. We studied all those patients which had been treated conservatively and the patients which has been treated in various groups in operatively. And it's very clear the non-operative treatment never leads to a significant reduction. There is always a mild placement. While doing surgery, things are always coming to a proper level. And that is what we published subsequently. Then we try to look it out whether this displacement, residual displacement, matters or not. So we compared these patients also, and we found it out, yes, the outcome is surely linked to the residual displacement in the posterior part of the sacroiliac joint, posterior injury. So it does matter, and that is again published. Now, if these patients were not treated appropriately or they were neglected, there were non-unions. Here is a patient who had a non-union. You can see it over here. This fixation is also losing out, and he's not able to properly put weight on the affected side, needs a support to stand up. So we went posteriorly, stabilized posteriorly, and now you can see he can be up and above and independent except. Another patient with exactly the same kind of a spectrum and is unable to walk around because it has not been stabilized. So what we do was a very simple surgery, going backward, stabilizing across, and you can see he's independent now. This is another case who was on bed for 7 months, not able to walk around because of those non-unions persisting posteriorly. So we just went in, stabilized all of them to make him sufficiently independent. This is a child who came from Leh, who with a 1-month-old injury. There I tried to reduce posteriorly. Anteriorly, my fixation went in the very next day, but he went on, and this is a subsequent follow-up. He developed a reasonably good outcome in his case. Then many patients who develop these displacements, they wanted correction also. So in this case, we went for surgical correction to reduce that osteotomy at that place, and this thing also to a reasonable level. And this is all what we could publish out of our experience of this neglected pelvic. Now shifting from pelvis to acetabular fracture. While pelvis trauma, primarily we talk about mortality, then we talk about morbidity. In acetabular trauma, primarily we talk about morbidity in these injuries. Now the traction as a treatment, which looked to be acceptable at one level, I mean, this reduction can be taken as was taken as an acceptable, but that was leading to a degeneration, and this lady had a problem within 3 years of this pelvic trauma, acetabular trauma. But there was another case which I saw in the HP at that time when we had no knowledge about it. We treated him on traction, and this look him after 9 years. He has got the full functionality to sit and squat. So this itself was intriguing. Why some cases go too well, why some cases are bad thing. Now, whether traction is effective, this is a young lady. No, this was a lady, mother of a doctor, who came to me at that time when we were not doing much. I thought this was quite okay, can do with the traction, did traction, but the traction displaced. The traction cannot manage these unstable injuries. Then we published it in the Journal of Trauma, our observation about cases where we had been able to manage reduction and maintain that. And this is the outcome was that whenever we could manage, even with conservative treatment, reduction, the outcome was not met. So it is the reduction quality and the ability to manage that is important. And now we understand all these fractures are primarily distributed into 10 types, depending on which part is involved. It's the wall involvement, or it's the column involvement. It's the anterior column, posterior column, or a various combinations which we can have. And specific set of x-rays required, an operator view is required, a iliac view is required, and a specific signs can be elicited to define these 10 types of gap. CT now is an essential part because you tend to see the intra-articular fragment, tend to see the joint surface, the impaction, the acetabular wall, they're all important. But what is very important is to understand why this patient with the reduction is doing very well after 6 years, while the same patient is not doing, because we can understand the roof is broken. That roof, that so-called weight-bearing dome, is an important part that we understand. Now here again we see the same roof. Here also roof is intact, here roof is intact. But here his hip is still normal. Here this hip is degenerated already. What is the difference between this weight-bearing dome and this weight-bearing dome? We can all appreciate this is a reasonably adequate. This is much less than that. You can expect stress, and that is very good. And this is what is called as Mehta's angle, where we have got the center of this arc of the residual acetabulum. From that center, the edge on the fracture. If it is less than 40 degree, probably it is inadequate. If it's more than 35 or 40 degree, this is adequate and can be treated conservatively. Another factor, here also this is inadequate, here also this is inadequate, but he does not have a problem after 5 years. He has got a degeneration within 4 years. Why so? Again, we have to notice that this femur head is in congruency with this roof. Here, this femur head is not congruent, it's more congruent with this thing. So there is a, so congruency with the roof is also very important factor in defining the outcome. So whenever dislocation happens, definitely our first step is to reduce this dislocation. That definitely remains our first step. But then once we have reduced, the question comes whether I have to operate upon or it is stable. So definitely we must look for stability of reduction. And this is one of that example. You can see how do we look for. We just have to flex and you can see that click. So that is the instability which will make a definite indication if our reduction has been done. Another issue comes a kind of a fragment in the joint. So fragment in the joint, if it does not make the joint incongruent, can be treated conservatively. But a fragment in the joint which makes the joint incongruent must be removed, whether arthroscopically or whether by compromise. And whenever there is a irreducibility that has to be opened, associated injuries, they all need surgery. Now, most of these posterior injuries can be managed by Cocker leg and mat approach, where we go posteriorly, take the rotators carefully, and get into the joint. And all these posterior injuries, these are the most common injuries we encounter in orthopedic in pelvic trauma. And the wall is broken, so we need to support the wall and buttress it with subsequently a plate over this. We might need some kind of a manipulative reductions for maintaining that wall, and these are the reductions required. But if done, this is the outcome of 5 years, 8 years, 11 years outcome with this kind of a reduction. Many times that is comminuted. So in addition to a screw, we might need some plates, as you can see, a T plate here and this T plate here, which is holding that comminution of this area. Whenever posterior column along with wall is involved, we need to reduce the column first. Once the column is reduced, then we concentrate on the wall, and then the wall is reduced. So these are the cases where we have done the column reduction and the wall reduction to give an acceptable outcome. Then there could be a transverse fracture getting into the anterior side along with the wall fracture also. Again, here we reduce the wall and then we pass through this the column into the anterior screw to hold the anterior column also. In some cases, we do use a trochanteric flip osteotomy to go anterior for that reduction. Incidentally, here is a case where it required extensive reduction, but the posterior wall was badly comminuted, not reconstructable. So we used a iliac rest graft and we could publish that as a new observation. This is 10 years follow-up, which we have been able to get it over. Now we shift to anterior column injuries. Anterior column injuries, now we need to approach them from anterior side. Now, which out of approaches? Either we use a conventional ilioinguinal approach, or we use a iliofemoral approach, or we use a modified Shobha's approach. We need to pick up whichever area it is. Ilioinguinal approach is the master approach developed by Rujuta internal, where we go from the front side of it, go through area, define this iliopectineal fascia, cut this fascia, and Once we enter in, then we do reduction in these three windows, the lateral window, reduce and fix, and the middle window through which we reduce and fix by taking our vessels outside. And this is the kind of the surgical reductions we are likely to achieve with this to give a good outcome to the patient. Next is the iliofemoral approach, which is basically the lateral window, which is enlarged now. Now, this approach I had done in 1997. At that time, didn't know it. I was doing the Smith-Peterson for this femur head fracture, where I just went proximally, found if I do osteotomy of anterior pelvic spine, I can make it a iliofemoral, and that is which I did it. She subsequently was okay for many years. 19 years later, she had a replacement, and she was with me to tag me for my first surgery itself. So this is the iliofemoral approach, in which we go by osteotomy of the anterior pelvic spine, get lateral window, reduce it up, and we can put plates across. And these are the cases which have been operated by using this iliofemoral approach. In this approach, we also kind of thought of a new procedure why to fix this anterior column and to avoid going into very thin line. We proposed a safe technique of putting a screw that we enter from the outside anterior inferior spine, we come out and we re-enter, and that is what we have done. And this could make the fixation easy. And this, as you can see, the fixation from the plates, they have come to screws. It could be an isolated fracture. It could be in a combination with pelvic injury, or it could be both anterior in the case of a transverse fracture, fix posterior column and fix the anterior column through this. Another approach which came is AIP approach, that is the medialmost window of a Chairpersons, which is a large to look inside into the pelvis. We stand on the other side, we look inside, and we can do the fixation inside. And the concept is now here you can see it out. The femur head has come interiorly, it's pulled out, and thereafter this plate is applied inside, and this plate is applied to buttress the things. Well, another advantage which we get from this AIP approach is because there is usually a compression fracture or impaction which you can notice. This impaction can be reduced by K-wires through this medial window, and here this window and a plate has been applied over this to get stability. Now, looking at the implant, this was a new plate which we patented way back in 2007. It had some problems, so we left it. In 2014, again, working over these injuries, working over these dimensions of the pelvis, we noticed in relatively elderly, there's a typical pattern with an excessive combination. So we developed another plate for this kind of area with IIT nearby. We worked out the biomechanics of it, and then we could produce this plate, which is mostly done by AIP approach, gives us a reduction to this fracture. As the plate is getting a kind of a pressure over there, it reduces, you get beautiful reduction also, and which you can stabilize it also in the subsequent. And primarily for the elderly, here you see a 66 years man with this kind of a reduction, he is 69 years of man with this kind of a outcome for his injury. Subsequently, things changed to percutaneous fixation also. Here, this is an anterior column screw, which is done with minimal open reduction. You put it over there, you can pass a guide wire, thereafter you can pass a screw across. You can pass for posterior column. It could be retrograde, going from this side up, you define it out, put a guide wire and put a screw, or it could be antegrade, that you define a window over here and then go into the antegrade manner. It could be ilio-iliac screw. Here, because of the vascular injury, I did not want to open the hematoma, so I put screws percutaneously into this area after reducing with the fixator. Or in this, which is minimally displaced, did a reduction and put a screw. You can see the screw going into the column over reduced screws. But we should not forget that there are likely to be complications. This is the osteoarthritis is the most common complication, then heterotopic ossification, even etc. can follow. But very important, we have not to miss is to perceive that venous thromboembolism is the most important early complication, and it is essentially in 60% of the cases are prone. We have done enough work on that side and published accordingly. A lot of emphasis they have seen that we should not understand that this is not common in our population, it's as common. Regarding avascularity, yes, we had patients who developed avascularity, and then we had our own perception that if we use a 50 cc syringe, do an aspiration from the head, if that aspirate is less than a cc, it is likely to be avascular. So on the table also you can do drilling here, we did drilling subsequently, and this is here follow-up, this is what published also. Then we also established that if we do an MRI at 3 months post-dislocation or post-acetabular fracture, we are surely likely to see it. If it is not happening at 3 months, subsequently it does not happen. That is our perception. So our team is to look for it. And what to do if it does not come back. So here is a case, 3 months MRI, show avian. We went on, we did a core decompression, and because we have been working on bone marrow aspirate also in consultation installation also, we did it. But after doing in these cases also the post-traumatic osteonecrosis, the results are only 50%. Just 50% not recover. Overall, we studied the outcomes of these patients. And what is most important thing which we noticed in the outcome, you can see, most important was the amount of displacement, fracture if it's complicated, but very important is the delay in surgery. If there's a delay in surgery, it is the least possible outcome. Here, sometimes we are able to reconstruct those. This was a 2-month-old injury, but we could get a reconstruction, and we did write on those kind of a neglected fractures also. But then there were fractures, 6 months old, 19 years young boy. We did not want to do any replacement, but had no choice because this posterior column was badly damaged. We had to do a reconstruction in this case. Then if the case is not managed appropriately, this was the case which was not managed appropriately, the THR done was also not done appropriately, and we had to do a reconstruction. So, or if the area is infected, in those cases we have to do debrima. Thereafter we have to do a replacement surgery for patients. Or there could be sometimes significant problem in this 21 years old lady with a bad injury was worsened, and she came to us after 2 years, where we tried to stabilize the vestibulum and then stabilize to get her a reasonably normal pelvis to walk. Then we did see that after the acetabular fracture, doing reconstruction has got its own issues, but its own learnings also, and that is what we have published in various articles subsequently. So now come over to teaching and training of this pelvic vestibular trauma. Yes, at the time when we studied, there were no opportunities. Today, we have got a reasonable number of opportunities. We have good number of books with us. There are many classroom teaching sessions, and now these days, lot of online teachings. But one thing which has brought me, and what I advise always is always to have a bone model with us, always try to recreate fractures on it, and then we learn to them. Then must attend cadaveric workshops. The best way to learn is going on the cadavers, learning about the cadaver workshops. Our EOPAS, and now which is APOA, is working on it and creating those kind of modules. EO has its own yearly, and after 2 years, these courses going every year. And other in KM, Dr. Namade is doing very good courses. In Lucknow also, they have a very good session of year by year, these courses going on. And then there are many societies, many states doing these courses. So we have got many opportunities now. In Ramaiya, every year, for some years till COVID struck us, we have been conducting regular courses with very good external international faculties, these courses where people have participated. Even in the developing world, in Nepal, in Bangladesh, in Myanmar, in Pakistan, in Bhutan, Sri Lanka, Thailand, Malaysia, I have been able to conduct these pelvic courses and all these facilities there. So overall, when we review it, this is a field of orthopedic trauma, which is quite exciting. It requires multi-dimensional thinking, planning, and execution, require fineness and skills, can change life of many patients, and many dimensions are there subspecialty. So I feel a kind of interest can definitely be generated into this field. Thank you. Good evening, friends. I'm thankful to Dr. Rujuta to have started this series of lectures in the memory of.
Definitely, you need to stop the video because sir is there actually in person with us now. And thank you so much, sir, despite the rush making it there. And I'm just sure your heart must have been in your mouth.
No. Incidentally, I have 3 more virtual talks subsequently in the evening. So,
oh my God.
So everything was signed up. But I'm thankful. I want to convey my thanks to Dr. Shobha Arora for the time when she was there from that time onwards as the first lady orthopedic surgeon. And I'm very happy that she's today with me in this symposium also. Thank you, Dr. Shobha.
Sir, good evening or good afternoon.
Yeah, good afternoon, Dr. Dhaval.
Great pleasure to see you. So, having known you for more than about a decade and a half, and knowing being through your journey, I just have two questions from this interesting talk that you brought up.
Please.
I think one thing that has made the difference in pelvic acetabular trauma in the country is a passionate way we have been able to teach it across the country. And I think it's a huge need base, right? Because I mean, there is a road safety webinar just going parallel, and I mean, you know that the number of trauma cases happen around. So that corollary comes to this platform that we are talking on, and I think that we must really encourage upon to Rujuta ma'am we must have one good lady female pelvic acetabular surgeon in every corner of India. We must have one face. I think
Agree.
That's a very important need, I would think, because we just get them. Okay. So
now
we
it is Dr.
With
Dhaval
Sen sir as the incoming president, I think we are already lining up the work for him. So that's
yeah, I think maybe we should be teaching. We should having an early training course for them in the early years of residency. I think we should do that.
Right. Yes.
Because I think the need is huge in our country. I would say there is just an ever increasing need. But yes, I think Sen sir is a mentor to most of us in pelvic acetabular trauma in India and even beyond in the borders. That it's behind him that everybody is following, and we want to educate more people. So good. Thank you, sir.
Thank you, Dr. Sen and Dr. Rujuta. You people have been more than kind to me, more than I deserve. And Ramesh has been a very long association colleague, and I have seen him grow in leaps and bounds. And definitely, he is a big name in pelvic acetabular trauma. So it's happy to hear him again. Ramesh, can I ask a question?
Please, ma'am.
See, most of these patients of ours who you also shown, and I think there's a classical article on these untreated fracture pelvis where the X-ray looks terrible, but the patient is doing pretty fine. So there's only a change in the biomechanics, and is it the benevolence of the patient, or you think conservative treatment of pelvis with a little malalignment is fine for function? If you can save the life.
Yes. The time when I got interested in this trauma, I actually looked back all the hospital records because we know nobody's doing it. So I started to look back what has happened to all those patients who have never been treated in the past years. And then we saw them. And many of them actually were not having problems. Some had problems, but they were not talking about it because for them, survival was the main thing. And once they're able to conduct their all basic activities, they were accepting it. As I told in one of my patients also, so when we really put them in a scoring system, we found their scores were not normal. But acceptability of our patients brings them to that level that in spite of that difficulty, a limp also, they are happy. And now in the pelvis, I'm not talking about acetabulum. In a pelvis, malunion about a centimeter will not affect him at all. Even 2 or 3 centimeter will not affect it. Some cases, wherever there are posterior injuries, and especially if it is a sacroiliac joint disruptions, are bad. Because they become painful in most of these cases, and there we have to do fusions or this thing. And then the other cases are the malpositioning leading to disability in sitting and standing. Now, these days I have been doing a lot of corrective osteotomies for the pelvis, their hemipelvis. We lengthen them, we realign them. And then we realize that there will be a group of patients who will really demand appropriate kind of a surgery. But if it is done in time, as probably if more and more pelvic surgeons are all around, then probably these late deformities can be avoided. And as far as undisplaced fractures, definitely simple bed rest is sufficient. And even in my practice these days also, whenever I have got a patient, right now we had a patient from Congo who was studying here in Chandigarh in one of the universities. She had less displaced fracture of the sacrum and this thing. I gave her a choice that you can lie on the bed for 6 weeks of period and you will be okay. Or if you want an early rehabilitation, we will put our screws and then you can be better off, and the choice is yours. Incidentally, every patient does not want to lie down if there is a choice to get up. And this has been at least 10 patients with me where I had given them a choice. You just have to lie down on the bed till the time the pain is troubling you. But the patients also now do not want to lie down that way. For acetabulum fracture, surely there is one pattern which say associate both column fracture, one of the 10 patterns, where conservative management is reasonably good in sizable number of patients. But all other 9 types probably need surgical reductions. Otherwise, they will have a morbidity. So that is what I sum up in pelvis and acetabulum.
Right, right. I just want to underline the fact that a bad looking X-ray need not mean a bad function.
Yes. And that was my purpose of showing all those cases also.
Yes.
That
Yes.
you have to be realistic,
Yes.
not to be dogmatic about that why this is so.
Thank you.
Dr. Ramesh, it's Tanya Burgess from Australia. That was an absolutely fantastic talk. Thank you very much. It was an amazing story of a professional growth throughout your career from the very start till now. And it was mirrored by the revolution of pelvic surgery throughout the years. And so I'm really interested, where do you think the future in pelvic surgery is? Like, what do you think is the next big thing in your field of subspecialty?
Incidentally, I am a member of AO Pelvic Expert Group. I represent Asia, Australia, New Zealand in that group, one of those 5 people group. So there we are working on what exactly the question which you're asking about. So there in that AO Pelvic group, we are working on some better designed implants, some better kind of a functional assessments, and especially if the hips are going bad, how these can be tackled. One main area which is coming up right now is elderly patients having acetabulum fractures now. In elderly patients now, we are weighing whether we reconstruct them and then subsequently allow them weight bearing and then replacement, or we in the very first stage, we do a replacement along with the reconstruction. So that is one very area which probably will be the focus as our generation is getting more senior and more senior people are likely to survive out. Probably that is the problem which is coming up. So in younger generation, things have been reasonably well seen. But in an elderly generation where we are now having more falls, incidentally, today morning I also had a recorded talk on the problem of osteoporosis in this country. And I had a lot of community kind of work in one of the daily webinars today morning. That was a osteoporosis only. So there I had enough data about talking about the osteoporosis coming up at 70 years, 80 years and 90 years of the population, where what we used to understand is a fracture neck femur. But now we get a lot of patients with the acetabulum fracture also. And this is a very difficult situation. Their bones are not good enough to do a replacement. And their bones are neither good because due to the osteoporosis, they're very comminuted case also. So in that situation, replacement is also difficult. Reconstruction is also difficult. So I think that's a big challenge which we are likely to face in the next few years to come.
Mm. And I noticed in your earlier slides, you were talking about the time from injury to getting definitive or even first aid treatment. And that's really a key in treating or you know, the life expectancy of the patient or the mortality. Considering there's so few pelvic surgeons in India and it's such a huge country, do you think there's any role for remote robotic surgery in the future, or being able to direct competent orthopedic surgeons from your area of expertise around the country? Is that a role or something in the future of pelvic surgery?
Incidentally, because we have been working on pelvic trauma all across, and incidentally have been in 2-3 pelvic courses in Australia also, in Cairns also, in Perth also, and in some of those courses also. In India, actually, we had a very good solution which is coming up. It is by natural means. We have got few orthopedic surgeons, somebody in Mumbai, somebody in Chennai, somebody in this thing. They are mobile surgeon, mobile acetabulum surgeon with their all kits with them. They have got links with all the orthopedic surgeon in that state or even the surrounding area. Wherever there is a acetabulum case, they go there, operate upon. The good thing is patient stays in his own setup. The patient is not to be shifted, so patient is comfortable. The treating surgeon knows that it is beyond his abilities, so he is also not bothered about. And this surgeon who is the expert is able to go to that place. So that way, at least I am aware of at least 10 surgeons across the country who are flying out to various places and doing that level of a surgery, which is a very high level of surgery, all these places. So I personally feel in Indian kind of a setup, that is a very good model which has come up. You do not have to be, everybody cannot be expert. And everybody, I mean, these cases are not that many that everybody will be able to, is required to do it. But some surgeon, right now we have about 200 surgeons who are doing it, but at least I know about 10 surgeons who are actually serving bigger areas by being mobile. So that could be one role model in that kind of a situation.
That's excellent. Well, I wish you well in getting more female surgeons interested in your subspecialty in the future. But no, that was it was a sensational talk. Thank you very much, Dr. Ramesh.
One last question from me, if nobody else has anything to ask. In children, when we operate upon bladder extrophy, of course, into otherwise. When we operate on bladder extrophy and do those osteotomies to try and bring the pelvic ring together, it's not every time that we succeed in getting a perfect pubic diastasis together, but we tend to leave it alone, saying that at the most it will cause a little bit of external rotation and out-towing, but it will not have functional disability. So are there any ways of modalities of fixing it later, or kind of devices which can bridge the gap, or would you recommend anything more?
Yes, because the posterior sacroiliac joints are quite okay. The whole construct is quite okay. So mechanically the child will have no problem ever. So that is not an indication to get over. Yes, anterior safety, anterior closure is required, can be done, and it is best done if it is in early stages. We do not have much of the experience because of our lack of we don't feel that we should be doing it unless until patients really demand it. But then we have got little experience in which, if it is done in that pediatric age group, we do have a kind of a containment of the content in that area. So it can be done to protect a bladder, to protect this thing area, but mechanically probably not required. I have got a lot of pediatric pelvic injuries where the patients have got deformities, displacement, but their bladder, because that gets frequently injured, and they are hanging on for 2 years, 3 years, 4 years, taking that bladder, bag with them, and that looks pitiful. I mean, that is something which we feel their bladder is much more involved than the bones. From the bone side, we have done okay, but with the bladder problem, they really continue for a very long time. So those disabilities are really troubling in pediatric patients also.
If I may be allowed to take that question, the chairpersons, if allow me. Dr. Rujuta, the experience with extrophy of bladder has two components. Number one is a young child, newborn, or an infant that the reconstruction is easy and it holds very well with plain simple posterior iliac osteotomies lateral to the sacroiliac joints. However, in this country, especially in government hospitals and charity hospitals, the other big problem is a neglected extrophy of bladder. A grown-up child whose bladder is looking after out of his abdomen and you are trying to put it back again. I have seen failures with the orthopedic part of it as well as more on the bladder part of it. So if you really are interested in reconstructing the pelvis, concentrate on putting the bladder in rather than just putting the bones together to look at the X-ray, which is a perfect alignment of the pubic symphysis. And let the urologist first take the way to keep the bladder in, and then ours is a small job to do. We can do it. We can do it once they are comfortable. Their failure is our failure as well. If the bladder comes out again, I have seen that happening. So if the bladder comes out again, your surgery is down the drain. So that's the priority. In a young child, newborn, if you are called for a newborn and an infant, go ahead, do the osteotomies, and plain simple closure of the pelvis works very well. I have been satisfied with that.
Right. Yeah, so I think that's an area we should look at further collaborations for. And ma'am, before we end, I think any other questions? And Dhaval bhai?
I can't ask him pelvic acetabular trauma because I think from him I can only ask that I think we need to make sure that we have more trained surgeons in the country.
Yes.
And especially with this, I think if you're saying you got 350 women, I'm sure we can get 20 of them trained in pelvic trauma.
290 as yet,
Yes.
not 350. I hope we reach 350 also.
Sure, we will. Thank you.
So at least we will need 10 to 15 lady orthopedic
Lady
surgeons.
orthopedic surgeons.
Yes, sir. Yes, sir. So you have a lot of work to do as a president now next year.
No. I'm definitely in mood that at least we should promote every part of orthopedics.
Right. So with
I'm happy to announce that my department in AIMS has a senior resident doing MCH pediatric orthopedics. She will be the first female MCH pediatric orthopedic surgeon doing official 3-year MCH course.
Excellent, and congratulations for that initiative.
Thank you.
So let's have some designs for her then. That will be nice. And before we do the vote of thanks, I would like to ask Shobha Madam and Ramesh Sensor for advice for voice. Of course, we will focus more on training in this, but in general, the advice for all the voice members.
Madam Shobha.
I have just one thing to say. Don't consider yourself to be different from rest of the community. We are all together. It's a profession. Whether a male or a female, you are doing the same job. So don't put yourself separate from them. We are just together. Right, Ramesh? We've been together. We've been doing our job. That's it. Why more females should be coming in, or why more males should be not doing this and that? So we are together. I don't consider females to be different from the professional colleagues. Lifetime 40 years I have been working in male departments, so you just are part of them. That's all.
My perception is that as a normal distribution in all other subjects, we have relatively more females vis-a-vis males as compared to orthopedics, where probably 350 is still not a very good number in front of 20,000 orthopedic surgeons across the country. So I personally feel, yes, there is no, as Dr. Shobha has already said about it, but an emphasis on getting the girls into orthopedics probably requires some role models. And probably those role models, if played by Dr. Shobha, Dr. Rujuta, and all our senior people, can definitely attract more girls into acetabular surgery, into orthopedic surgery. And I think that could be one of the ways for.
I think it comes more from your own motivation. My girls have been doing oncology. They have done excellent oncological work. They are doing pediatric orthopedics, and spine is also part of their work. So there is hardly any difference in that. Pelvic trauma also, somewhere girls must be doing it, and if they want to do it, they will definitely do it. I don't see a difference.
Yeah, I'm looking at orthopedics as such. I'm not pelvic trauma. So I feel orthopedic role model, lady as an orthopedic role model, more ladies.
You can be a role model to us also, Ramesh. That's not an issue.
No, the kind of a image, because everybody wants to be identified with some places. So there is a restriction, everybody is male. But if there are some ladies also doing at that level, probably that is something. And probably I'll now ask Dr. Dhaval to be taking special care. He is in a position in AO where he can definitely help that way. So rather than we can advise, Dhaval can do. So I'm putting the ball in his court at this moment for this purpose.
Some final remarks from Tanya and the role of APOA, if I may request.
Yes, of course. So I'm very proud to be the first chair of the women's advocacy group WAVES with the APOA, and I think that we're going to be very collaborative, both with all the groups around the world, IOTA, the International Orthopaedic Diversity Alliance, the W.O.I.C.E, the Indian group, as well as SICO and a few other groups. So hopefully we can all work together to increase not only the number of orthopedic surgeons, but also increase the orthopedic care of women in general around the world. And obviously fragility fractures and osteoporotic fractures is a big issue in all countries. So thank you for having me. It's been a wonderful experience and some lovely talks. So I'm very grateful for the invitation, and I look forward to seeing you all in the future.
So next week's webinars will be focused on spine. We will be having Dr. Rushma Tandon who will be speaking about degenerative lumbar canal stenosis. Does instrumentation really change the outcome? And Ram Chadda, who will be talking about artificial intelligence and robotics. Are they going to make the spine surgeon redundant? So with that, I think Chasanal, let's have our customary vote of thanks. And it's been an absolute pleasure hosting this.
Yeah, thank you everyone once again for joining us. And yes, today, this weekend is the spine weekend. Of course, we celebrate the spine day, and like ma'am has announced the next worthy webinars for the next week. And with that, we come to the end of today's webinar. And on behalf of W.O.I.C.E, I thank our respected chairpersons, Dr. Tanya and Dr. Desai, who joined us for this webinar. And of course, thank you, Shobha Arora ma'am and Ramesh Sen sir for the wonderful talks. And so it was wonderful to have the recorded talk and have you live for the question and discussion. It's great, sir. And looking forward to meet you at the IOCON shortly. And thank you, everyone. Thank you, OrthoTV, and thank you, Dr. Ashok Sham, for giving us this platform and letting us implement the worthy webinars here. And I hope this helps many more to get inspired and get into the field of orthopedics soon. And we have more such webinars in future. And I would like to also extend my thanks to the APOA Waves and WOW, of course, the Women Ortho Worldwide Group. And with this, we come to the end of our webinar today. Thank you, everyone, for joining us. Thanks a lot.
Thank you.
Thank you. Bye-bye.
Bye-bye.